giving me this opportunity on the stroke day to share my experience on the current trends in the management of acute ischemic stroke. As we know, acute ischemic stroke is something which has transformed in the treatment modality. When I was doing my undergrad and my post-graduation, I never realized that this disease could transform so much in the treatment strategies, and I would be part of it. I'm so lucky to be in this era when this transformation has happened. First and foremost, we want to popularize the term for an acute ischemic stroke, the term called brain attack. Because everybody knows about heart attack. The common man does not know about brain attack. Every time you call a stroke, people invariably misunderstand. They call a heart attack as a stroke. They come and say that they had a stroke, but we inquire in detail. They seem to say that they have had a heart attack. So there is a lot of miscommunication or misinterpretation by the public with regards to stroke. They don't realize the importance of stroke. As for the PGs, the brain is a very active organ, though it is only small in size, only about 2% of our body weight. It consumes 15% of the cardiac output, 20% of the oxygen that we take in and out, and 25% of the glucose that is being utilized by our body is being used by the brain. And it has no ability to store any of these energy. So it needs constant blood supply. Lack of blood supply for 5 minutes can cause a catastrophe. Stroke is not a new disease. It has been first described by Hippocrates about 2,400 years ago. He described it as an apoplexy struck down by violence. That's what he described stroke as. And some of the facts about stroke is that this disease is much, much more commoner than we think. It is more common than tuberculosis, malaria, HIV, AIDS, and even road traffic accident. It is that common. But we are not giving due importance to this disease because in the past days, no active treatment was available. But in today's world, active treatment is available. People have to be aware that such treatment is available. And among the cause of death, stroke becomes the third one. It's a third leading cause of death, but it is a number one cause of disability. A disabled person is much more worse. He suffers more than being dead, practically. And this disability does not affect the individual alone. It affects the whole family. If somebody is disabled due to stroke, the disability impairs him, and it also puts the caretaker in a negative balance. Practically, the caretaker cannot go to work, and the caretaker has to spend time and energy to take care of the disabled person. So it creates a significant economic burden to the whole family. Though no clear statistics exist, but even in the Western world, the statistics are not very clear, but the amount of economic burden is huge. For the postgraduates, obviously, you all know that there are two types of strokes. One is an ischemic stroke, other is a hemorrhagic stroke. Today, we are going to concentrate more on the ischemic stroke, especially the large vessel and median vessel occlusion. The ischemic strokes are much more common than the hemorrhagic strokes. The ischemic stroke constitute about 80% of all strokes, whereas the hemorrhagic strokes put together, intracerebral hemorrhage and subarachnoid hemorrhage put together constitute only about 20% of the strokes. And these ischemic strokes can be a large vessel occlusion or a small vessel occlusion. The large vessel may be an ICA, MCA, ACA, or up to M1 and M2 branches, beyond which it's considered a small vessel occlusion. Among these, the large vessel occlusion, the ICA, M1, A1 occlusions constitute to about, say, 30 to 40% of the occlusions or the strokes. The small vessel occlusion constitute the rest. When a large vessel is occluded, what really happens? If there are good collaterals, the brain survives. If there are no good collaterals, significant amount of neurons die. In each passing minute after an occlusion, about 2 million neurons die. And compared with the normal aging process, with each minute passing by, the person ages by about 3.6 years with every minute that passes by. The brain is fading away. What exactly happens is that the person is losing the memory, the person is losing his ability to talk, the person is losing the ability to walk, and if you don't act on time, they would be disabled for the rest of their life. And before we understand the concept of stroke treatment, we need to understand the collaterals. The collaterals, obviously, we all know about the circle of Willis, which is a major collateral at the base of the brain. It's so variable that for some people, circle of Willis is very well developed. For others, it's not well developed. If it is well developed, they all do well when there is a large vessel occlusion proximal to it. But we also need to know about the other collaterals, that is the leptomeningeal collaterals. The leptomeningeal collaterals are the collaterals that happen on the surface of the brain between the ACA and MCA, marked in B and C here. As you can see here, the B and C, these are the leptomeningeal collaterals. And between the PCA and MCA collaterals, and as well in the posterior circulation, we have very good collaterals between SCA, PICA, and ICA branches. So these collaterals are extremely important. It's not uniformly present in all the people, but it is so variable. For people who have it well, the brain is preserved. Obviously, we all know that the brain cannot survive beyond 5 minutes when the blood supply is cut off. But if these collaterals are good, the brain can sustain for hours and hours, and we take advantage of these collaterals to do a mechanical thrombectomy and reperfuse the brain. So this concept is extremely important, and we are able to assess these collaterals by various methods when needed. As we go on through the talk, we will discuss more about it. So this is just an example. This patient in the arterial phase, as you can see, there is an M1 occlusion. And during the early arterial phase, you can see already from the ACA through the leptomeningeal collaterals here, already the MCA distal branches are filling backwards in a retrograde fashion. In the late arterial phase, the MCA branches are filling well. And here you can see in the early venous phase, it's filling all the way up to the M1, up to the point of occlusion. This is the best case scenario you can have. These are the patients, when you do thrombectomy, they do recover completely and they do very well. And if somebody with a stroke is having these kind of collaterals, I feel so happy for them. What exactly happens when a large vessel is occluded? You get a core of tissue which is already destroyed. That is the core of the infarct. And the surrounding region, which is the penumbra, which is the region where these collaterals are sustaining or making the brain to just survive. And these are the tissue we are targeting to salvage and recover. So this penumbra, ischemic penumbra, is extremely important, and we need to assess how much of the penumbra can be salvaged. Just an overview of our recanalization treatment. As you can see in this picture, recanalization therapies have evolved over a large period of time. The first is an intravenous thrombolytics, approved in 1996 by the US FDA. Since then, there is no looking back. Even today, for the patients coming within the first 4.5 hours, IV thrombolytics has been the mainstay of treatment. Intraarterial thrombolytics were developed, but they never really got into big time, because at that time when it was developed, there were not many people doing interventions. Then came the endovascular thrombectomy, which became more popular in between 2009 and 2015, and it's now the standard of care. And now today, where we stand is that we have extended the window period of treatment to 24 hours in selected patients, not every patient, but in selected patients. So practically in the last 20 to 25 years, we have made a giant leap in the treatment of acute ischemic stroke. I want to run you through with how this evolution has really happened. The tissue plasminogen activator, that is the TPA that we call it, was approved in 1996 after this publication in December of 1995 by the US FDA. And initially they approved it for treatment of acute stroke in less than 3 hours. Even today, this drug is readily available in most of our government hospitals and in all the private hospitals. In government hospitals, it's available free of cost, and it is being done even in the district hospitals. You don't need a big setup to give this thrombolytic medicines. So in 1996, this was approved. Then people developed in 1999 for the first time, intra-arterial thrombolysis was proposed. Various studies were designed, but it never really got into big time because at that time, there were not many centers doing endovascular treatment. Then they combined intravenous with intra-arterial thrombolysis. Again, there were various trials proposed. By the time this was becoming popular, mechanical thrombectomy devices were coming into picture. And they also tried doing this intravenous followed by intra-arterial thrombolysis along with an external ultrasound kept near the temporal region and providing an ultrasound to lyse the clot. This was one of the innovative ways of lysing the clot which was proposed, but it never really got big time because mechanical thrombectomy was much, much superior, and it got into vogue. By this time, these treatment trials were proposed. And in 2008, this NEJM journal publication from Europe, that is a European Cooperative Acute Stroke Study, ECAS-3 trial was published, which extended the window of thrombolysis from 3 to 4.5 hours. Even today, this is the standard of care. Today, we treat patients with ischemic stroke for up to 4.5 hours with thrombolytic medicines. So that is where we stand. That is the standard of care today. Today, we have moved on from Alteplase to Tenecteplase. Alteplase is a recombinant version of naturally occurring TPA, and it binds only semi-selectively to fibrin-bound plasminogen, whereas Tenecteplase is a bioengineered variant of TPA. It is more fibrin-specific, more resistant to degradation by endogenous plasminogen inhibitors. And compared to Alteplase, Tenecteplase has a longer life. That is, it acts in the system for about, say, 20 to 25 minutes, and it lasts in the system, that is about its 3 to 4 half-lives, about 90 to 130 minutes. And preparation is much easier, and it is a single shot infusion, single shot IV bolus which is given, whereas Alteplase, we usually give 1/3 as a bolus and 2/3 we give it as a slow infusion over 45 minutes. So for Alteplase to complete, it takes about 1 hour, whereas Tenecteplase can be given as a single shot IV, which takes about 5 minutes. So and moreover, more than all these factors, Tenecteplase is relatively cheaper than Alteplase. So Tenecteplase is the drug of choice in today's world in most centers. As far as the endovascular treatment to the stroke is concerned, the concept of endovascular treatment was existing before, but people did not have the right device. People in the past before were using various devices, like they would partially deploy a coil, partially deploy a stent, and try to remove the clot or macerate the clot to lyse the clot. People have tried various things, but the concept did exist, but the devices took time to develop. It was in 2004. That's when the first device was designed. This is called the Mercy device. This device is more like a corkscrew. We would have seen this like it's more like unclogging a drainage pipe. We put it in and then we pull it out and try to remove the clot. Various developments happened to this device. They added nylon wires to it, and then all sorts of improvisations were done. But the problem is the access device. The catheters to gain access to the tortuous vessels did not exist. I mean, I have done my first thrombectomy using the Mercy device, but at that time, the guiding catheters were so stiff, getting into the right artery took a long time, about 45 minutes, 1 hour for us to gain access to the vessel. And then using this device had a high rate of failure. And the success with this device was only about 40%. Say with thrombolysis in a large vessel occlusion, the success rate was about 20%, whereas the Mercy device improved the thrombectomy by about, say, another 20%. So our success rate was about 40%, and we still had about 60% failure. Then came the new device called the Penumbra device. This is more like a suction catheter, which is applied to the clot. The catheter came in various sizes, the larger one, the medium sized one, and a smaller one. And then it had a bulbous tip wire-like thing, which is called a macerator. So practically we put this catheter on the clot, and then at the other end of the catheter is a suction pump. So suction is constantly sucking the blood, whereas we macerate the clot with this. So it was a wonderful thought out design. And we were able to achieve about, say, 75 to 80% recanalization using this Penumbra device. So it was a real game changer. And when this device came into market, that's when thrombectomy became more and more popular. Then came the dawn of the new era, that is the stent retriever. When the stent retriever came, it made a whole lot of change in the way we treat acute strokes. This was an accidental discovery. People deployed stent partially. Initially, they had a stent only for aneurysm base bridging, and it was deployed partially on a clot. And when they pulled it out, it worked wonderfully well. Then people thought that we could just make the stent fuse to one of the end, non-detachable stent, which we can retrieve. So it's called a retrievable stent, which is deployed on the clot, and the clot is retrieved, which is left for about 5 to 7 minutes. What exactly happens is that with the body temperature, these are pre-shaped nitinol metals. So with the body temperature, it expands and grabs the clot in about 5 to 7 minutes, and then we pull it out to extirpate the clot. Today in the market, we have about 7 to 8 stent retrievers, and we can choose between one and the other based on the efficacy and personal experience. So the stent retriever was introduced in 2012, and from there on, no looking back. This is how the stent retriever works. I'll just show you a short animation video. The clot is blocking the M1 here, as you can see. First, the wire is passed across, the microcatheter is passed across, the stent retriever is deployed and allowed to expand with the body temperature. It expands and grabs the clot. As you can see here, it expands and grabs the clot, and the clot comes to the center. We arrest the flow in a balloon guide catheter, and then we pull the clot out. It may not work in a single pass in all the cases. In about, say, 30 to 40% of the cases, we'll get a single pass recanalization. In others, we may have to use a multiple pass recanalization. And with this, revascularization scale improved from TICI 2 to TICI 2B. Practically, that is when we achieve significant amount of recanalization. TICI 3 is a complete recanalization, whereas TICI 2B is what we want to achieve in every case possible. If possible, TICI 3 is what we want to achieve. An example where we have used a stent retriever in the initial stages, this was a 74-year-old male with the hypertension, dyslipidemia, MA about 8 years ago, had a coronary stent placement on Plavix. He came to the ER, found down with a right MCA syndrome, NA stroke scale of about 18. Initial CT was looking normal, and the TPA was given, and immediately patient was taken to the cath lab for intervention. As you can see here, oops, yeah, there was a right M1 block. The stent retriever was placed. As you can see, the stent retriever is quite visible, and this is placed across the clot. You will see that it is pinched in the beginning, and then when you leave it for about 5 to 7 minutes, you can see the stent retriever practically expanding in front of your eyes. And once it expands, that's when you have to start pulling them out. So complete recanalization was achieved. Patient made a very good recovery with a small residual infarct. That is the core of the infarct, and the penumbra is what we have salvaged. And when these were happening, there was a significant drawback. The IMS-3 trial, MR rescue trial, synthesis expansion trial, these trials gave a negative impact on thrombectomy, but we all know that the thrombectomy works. In spite of all these negative trials, the thrombectomy became more and more popular because we know that it works. Then came a device for direct aspiration. This is a catheter where we put it all the way across up to the clot and do a direct suctioning aspiration. This catheter was an finding of a trainee in one of the companies. What they did was, usually the catheters have a transition zone. That is, the proximal part of the catheter is very stiff. When you go more distally, close to the brain, it becomes more and more softer. Usually, most catheters have 3 transition zones. Here, they kept about 8 transition zones, which means that it becomes progressively more and more softer, and the tip inside the brain is extremely soft for you to advance it more safely into the brain blood vessels and grab the clot. So this one was a game changer. And the direct aspiration works like this. You put a microwire, microcatheter, and then take this catheter all the way up to the clot, leave it there for about 5 to 7 minutes, and apply a constant direct aspiration. And it grabs the clot. Once there is no flow in the system, you can pull it out safely after having a balloon guide and arresting the proximal flow in the ICA. So this technique is called ADAPT technique. So this was one such case initially done with this technique, and this catheter goes through the vessels quite well. As you can see here, there was a 360-degree turn here, and you can see the catheter climbing up quite easily and freely over the wire and microcatheter, and you place it across the clot. And it is quick time. With this catheter, we have done thrombectomies in a very fast time. My personal fastest time is about 12 minutes from the time of puncture to taking the clot out. People have done it even in less than about 10 minutes. So in the initial stages, doing it in 20 minutes was a big achievement for us. And this is what we achieved using this catheter. So this was one such clot removed from the MCA. And this catheter became better and better. Initially, it was a 060. It was a 5 French catheter with the diameter of about 060. Then it improved to 064 with the multiple transition zones. And they made it like a 14 transition zones. And Then it improved to 068. And today we have about 072. As you can see here, the red catheter, which was recently launched, is 072, which is a large bore catheter. The amount of suction applied, this is a very powerful engine and creates a negative pressure of about -30. And using this catheter, most clots would come out. And it's a snug fit with the MCA. It's not oversized. It's designed in such a way that it's a snug fit with the MCA. This is one such patient where we did a direct aspiration thrombectomy. Usually patients who have these kind of lenticulostriate collaterals preserved and the clot is distal to it, they do quite well. And if they have a leptomeningeal collaterals, they'll make a complete recovery. So this patient, the CTA shows a left M1 occlusion, as you can see. With the direct aspiration thrombectomy, complete recanalization was achieved. We'll just see few cases as we go along. This is a 63-year-old male with a hypertension, diabetes, AFib. Last known well about 4 p.m. reached the hospital at 6:30 p.m., 1.5 hours. This patient in the ER became lethargic with a disconjugate gaze and mild quadriparesis. NIH stroke scale worsened, and he was intubated right away. This was the CT scan, which was not a great CT scan. He had strokes in the past, and the CT angio showed a basilar occlusion. The basilar occlusions does not classically present like an acute stroke. They may present with the variable symptoms. A lot of them is mistaken for encephalopathy or drug poisoning or alcohol-induced changes if they don't have a clear history. So we have to have a high index of suspicion to pick up these basilar artery occlusions. So this is the basilar occlusion, pre-thrombectomy, post-thrombectomy. This aspiration catheter is wonderful. As you can see here, we are taking the catheter up. You just follow this. It tracks up so well. We are not using any lead wire or the catheter. The aspiration catheter tracks up. We are putting it right at the clot, which takes few minutes to do. And this was the clot that was removed. The patient made a dramatic recovery following thrombectomy, and in about the next day he was extubated. 1 week later he was discharged. In about 3 weeks he is back in the office completely normal. Without this treatment, this person would have been disabled for the rest of the life, and he would not have lived a life after this. So this treatment is really a game changer, and it's making life better for people whom we can help with. Age is not a criteria. Even people older than 80 years, even people older than 90 years, we are able to treat. The oldest one I have treated is about 97 years. This one was an 81-year-old female with a premorbid MRS of 0. Patient was practically normal, doing all her functional activities and was doing calculations and was able to take care of her accounts and everything. And she developed stroke while drinking coffee at 5:30, came to the hospital at 6:30, and her stroke scale was 18. CT brain was normal. As you can see here, the CT angio showed a left IC occlusion. This was a left IC occlusion. It was a distal occlusion just beyond the ophthalmic. We are putting the microcatheter over. Using a stent retriever and direct aspiration combination, we are able to remove the clot. So just a few examples. So these are different types of clots that has been aspirated. Some are red clots, some are white clot, fibrant clots. But irrespective of the type of clot, in most situations, you'll be able to remove. The clots come in various shapes and colors and constitution. But people have been doing a lot of research with these clots, but they are not able to figure out which one will work better. But most of the time when we get a white clot like this, that is when we are apprehensive, because if it's a primary atherosclerotic disease of the MCA, the vessel may shut down, and again, we may have to do an acute stenting. So as we are progressing with a stroke thrombectomy, in 2015 and 16, multiple positive trials came. First was Mr. Clean. All people treated with mechanical thrombectomy in Netherlands were evaluated, and they found that this mechanical thrombectomy works for them, and the trial was prematurely stopped because the results were very good. Then came the ESCAPE trial, Extend IA trial, Swift Prime, Revas therapy, Trace trial, and to date, we have about 10 to 15 trials which have become positive for endovascular treatment. This is a this is a 34-year-old male with a sudden onset right-sided weakness. Age, as we see more and more in Indian scenario, we get more and more younger people developing strokes. This was a 34-year-old male, and he developed stroke at about 4:30 p.m. He came to the hospital by about 6 p.m. This was the MRI showing the changes. the patient stabilized and the neurologist thought he's going to manage him conservatively. But he deteriorated again. The repeat MRI showed that the left ICA flow was significantly getting blocked, and the left ICA was not very well visible in the follow-up MR. And this was the initial angiogram showing a large clot burden in the ICA at the origin. There was a ruptured plaque and the clot was sticking to it, and he was throwing clots more and more into the brain. And there was a tandem occlusion, proximal occlusion, as well as a distal occlusion just proximal to the ophthalmic artery origin. Here we aspirated the proximal clot, went with the stent retriever for the distal clot, and aspirated the clot out. As you can see here, this was a large clot thrown into the brain, and a good recanalization was achieved. Most of the time, we don't try to achieve a perfect angiographic result. This kind of a floating thrombus or a clot which is stuck to the wall will resorb itself with conservative treatment, and they will do well. So this was a follow-up MRI of this patient. I mean, the CT scan the next day. There was a little reperfusion, bleeding in the basal ganglia. Except for that, the patient made a very good recovery with the mild hemiparesis, which recovered at 3 months of time. This was a 61-year-old female with a past medical history of hypertension and diabetes, sudden onset right-sided weakness, and CT scan initially was normal. IV tenecteplase was given. There was an IC occlusion. As you can see, we went ahead and removed the clot. And this patient, after we removed the clot, there was a little clot thrown into the distal vessel. As you can see here, the distal vessel was blocked. And then we were, in today's world, we are able to go into these medium vessel and small vessels and remove those clots as well. So this was a clot migration into the more distal vessel. We chase them down and remove those clots. And with this thrombectomy business, we have to be aware that not everything is beds of roses. We then and there get into a situation where we do everything perfect, but we will get into a bad result. So, and these bad results is beyond your control, because these people lack the leptomeningeal collaterals to make the brain survive till the time we go in and reperfuse. This is one such example, a 58-year-old male with the past medical history of diabetes. He was last known well about 10 a.m. and he was found to have stroke in the office. So everybody saw him practically have a stroke. He was brought into the hospital at 12 noon in time for us to treat. In his initial NIH stroke scale was 19. As you can see here, this was the initial CT scan, the M1, left M1 occlusion. We went ahead, did a thrombectomy in a real quick time. We were able to take the clot out in one chunk, and the clot became clot came out in a quick time. We were able to achieve good recanalization, but the patient did not make a dramatic recovery. In the following hours, he became more and more drowsy and lethargic. We repeated the scan. He had a large stroke with the mass effect. We had to go ahead and do a decompression. So this was post-decompression, post-tracheostomy, and the patient remained at hemiplegic. So these are the results we may get in certain situations, but these are off cases, and the chances that when you do a thrombectomy and remove the clot, the chances that the patient could improve is about 60%. So you have to counsel the family quite well. And we look at the MRS scale at 3 months, and that's when we assess the outcome. So for any stroke patients we treat, we assess them at 3 months for their final outcome. That is what the studies show. This was the initial trial, which showed that without intervention in the control group, the number of people who landed in MRS of 0, 1, and 2 were relatively less compared to the ones which landed following intervention, were significantly higher. That, which means that there are more and more people we are putting from MRS of 3, 4 to 1 and 2. That is what we are achieving with this mechanical thrombectomy. People have to be aware that not every thrombectomy we do, a patient will do a perfect clinical recovery. That's not the case, but we make them better, and they have a relatively good functional recovery at 3 months compared to the control group. And now we come to an era where the window of thrombectomy has been extended. You have to understand the concept of ischemic penumbra. We spoke about the core and the penumbra. The penumbra comes down as the time goes on. In the first 6 hours, the penumbra is larger. As time goes on, up to 24 hours, the penumbra becomes smaller and smaller. We have to pick up those patients who will benefit with the thrombectomy. And there were 2 trials. One was the DAWN trial, which showed that yes, in positive, properly selected patients, they will benefit with mechanical thrombectomy. As you can see here, compared to the control arm in patients where Trevo was used, between 6 and 24 hours, there was a good clinical improvement in properly selected patients. And this is a subgroup analysis. And then the diffuse trial also showed a similar finding. This was a diffuse trial where they did a thrombectomy in patients between 6 and 16 hours. They did a CT perfusion or MR perfusion related assessment, and they showed that patients properly selected will have a good recovery. So this is a CT perfusion images. We look at the regional blood flow, regional blood volume, mean transit time, and the time to peak. We take all this into consideration and assess the patient to see which patient will benefit. Patients where the regional blood volume is less, blood flow is relatively reduced, and the mean transit time is relatively increased, those are the patients who will benefit with mechanical thrombectomy. Today, we have the RAPID software, which gives us all this information because the CT perfusion is not readily available, or the CT perfusion is reading is extremely difficult. So this RAPID is introduced, and RAPID is quite expensive, but it's a useful tool which is for dummies. Practically, it gives you the information in a color-coded fashion, and the patients who will benefit with mechanical thrombectomy can be selected. As an alternate, if you have an MRI in your hospital, that is even better. So we look at the DWI images, ADC images, mean transit time, the flare images, and the echo gradient to assess patients who will benefit with mechanical thrombectomy. For patients with the large vessel occlusion, if the DWI shows changes and there are no changes in the flare, so these are the very simple algorithm I've taught my residents. They will pick up and tell me, sir, there is a potential patient. So that's how you can train your team. So, and these are the patients who will improve well. As you can see here, mismatch between DWI and flare are the ones who will improve. If there is a matching defect between DWI and flare, those are the patients who have an already established infarct, and you may not be able to help them. So for patients coming between 6 and 24 hours, we do either a CT perfusion with or without a RAPID software, or we use a MRI to assess which patients will improve with mechanical thrombectomy. So this is an extremely useful tool to have. So the bumper sticker message today is that the updated guidelines from the AHA also tells us that mechanical thrombectomy in select patients from 6 to 24 hours after the stroke begins is extremely beneficial. So the guidelines of the American Heart Association goes like this: for patients coming within the first 4.5 hours, IV Alteplase or Tenecteplase should be given level 1 evidence. And we don't wait for seeing a clinical response. As soon as we give this Alteplase or Tenecteplase, we get the cath lab ready and move them. Waiting is harmful. That's what the guideline says. And for any patients more than 18 years of age, this is the level 1 evidence I'm talking about. Even outside the age group, we do treat. More than 18 years of age, less than 80 years of age, who have an aspect score in the CT scan of more than 6, and NI stroke scale of more than 6 are the patients who will benefit with mechanical thrombectomy, and our level of evidence is quite high. And today we have large vessel occlusion. The level of evidence is high for small vessel and medium vessel. We have moved forward to the medium vessel occlusion. The level of evidence is relatively low, but the evidence is mounting, and people are trying to designate patients who will benefit in smaller vessel occlusions as well. So with the DAWN and diffuse trial, we have level 1 evidence for 6 to 16 hours and level 2A evidence for 6 to 24 hours for stroke thrombectomy. And we always try to achieve either TICI 2B or 3 recanalization, the recanalization score I was talking about. We'll see a few examples of wake-up stroke. 65-year-old male with a wake-up stroke with the right hemiplegia. The initial CT brain was normal, and the CTA showed a left IC occlusion. Obviously, these are the patients. A perfusion scan is done, and we see that there is a large penumbra. And these are the this patient was taken up for mechanical thrombectomy with an IC occlusion. This is following thrombectomy. This was the clot, and this was the follow-up MRI. And following thrombectomy, the patient's NI stroke scale marginally became better. From 16 to 14 on day 1, his NI stroke scale even improved to 6. And that's how most of them improve. So these are the few examples. Okay, as far as the endovascular intervention is concerned, we are today pushing the limits. We are moving from large vessel, that is a basilar occlusion, IC occlusion, M1, A1 occlusion, to more distal locations, to ACA, M2, and even to M3, A3, and as well as to PCA and other locations. That is some PICA and SCA branches as well. We are able to open because we have mini stent retrievers, which call catch view mini, and there are so many mini stent retrievers are possible, which we can safely put across these branches and open them up. A few examples of distal vessel occlusion. There are so many papers coming out on DMVO. Previously, they call it as a LVO for large vessel. DMVO is a newer concept wherein we are able to do thrombectomies for these small vessels. This is a left hemisphere, it was a right ICA occlusion. As you can see here, there was a distal vessel that was blocked. We're able to, this one I did a thrombectomy using a direct aspiration catheter and achieved a complete recanalization. The TK3 recanalization was achieved. There's another patient with a distal M2 occlusion. You can see here, put a stent retriever across, and this was the clot that was removed. This is after recanalization. This was one of the recent cases did about 2 weeks ago. You can see there was this is the M1, M2, then it's a M2 to M3 junction. You can see, put a stent retriever across and remove the clot out with a complete recanalization. So today we are able to push the limit and do thrombectomy at even a more distal location. Creating public awareness is extremely important. People have to be aware of that, because stroke is a painless disease. It's not painful. Unlike a heart attack, they don't come to the hospital on time. They think that their hand is not working, but over a period of time, it will get better and they will sleep over. People have to be aware that when some part of the body is not working, they need to come to the hospital immediately. For the postgraduates, when you assess a stroke patient, the most important history is, when was the patient last seen normal? Okay, that is extremely important. That is considered the time of stroke. If somebody goes to the bed at 9 p.m., wakes up morning with a stroke, then 9 p.m. is considered as a last seen normal. For example, somebody sees somebody waking up and going to the bathroom at 12 midnight, and then they find them with a stroke in the morning, then that 12 p.m. When you're assessing the patient, it's very important to assess the pre-morbid functional level. Patient who are wheelchair bound, who are disabled, who are demented with Alzheimer's and other problems, we don't really treat them. If the pre-morbid functional level is good, those are the patients candidates for mechanical thrombectomy. And pre-morbid clinical condition includes diabetes, hypertension, or any other diseases like peripheral vascular disease, and cancers have to be taken into consideration before making a clinical decision. Then comes the clinical assessment and imaging. So the time of onset is extremely important. The reason is that we do IV thrombolysis for up to 4.5 hours. And for candidates between 4.5 hours and 6 hours, we take them to mechanical thrombectomy. For patients who come beyond 6 to 8 hours and up to 24 hours, we do advanced imaging to assess for ischemic penumbra and then take for mechanical thrombectomy. So these are just the clinical assessment, neurologic assessment. The most important aspect, as we measure the GCS score in every RTA patient. For stroke patient, the most important assessment, at least for interpersonal communication, is the NIS stroke scale, which gives a realistic assessment of the clinical condition of the patient. It may look cumbersome to begin with. When you start assessing the NIS stroke scale, you have an app online. You can download. These are the free apps. You can download and start marking. It usually takes about 2 to 3 minutes to mark the whole thing. So you can do that, and it gives you the score in the end. So this is a very, very useful tool to have. Obviously, the imaging, CT scan is the most important imaging for patients who come early. And you may see a normal CT scan like this. You may see a hypertense FCA sign. And the most important thing is, if you see a loss of gray-white junction in this normal hemisphere, you can see the gray-white differentiation is maintained. Whereas here, with the onset of stroke with an established infarct, you will see the loss of the gray-white differentiation. And then you assess the aspect score as well. Aspect score is a score of 10 is given to a normal CT scan, and then you reduce based on the area, the number of areas infarcted, where you have gray-white differentiation loss, or there is a hypodensity, you reduce the score. If the score is less than 6, generally not a candidate. More than 6 is a good candidate. But now the concept of doing mechanical thrombectomy for lower aspects is catching up in the Western countries in the last few years. Then we do a CTA. Obviously, any patient comes within the first 4.5 to 6 hours. We do a CT with CT angiogram to look at the large vessel. The CT angiogram covers from the arch to the brain. So we can plan the type of device and the type of arch, and all those, the tortuosity of the vessel are taken into consideration while planning the procedure. For patients coming late, obviously we do CT perfusion and MR images to assess. We have spoken about it already. And quality control measures. What do we do in acute stroke? The most important thing is we don't have control on the patient till we reach us. Once the patient reaches us, we should have good control of our system where we can provide faster care. Door to CT time should be less than 20 minutes. Door to needle time, that is thrombolysis, has come down from 45 to 60 minutes in today's world to less than 30 minutes. And door to puncture time is actually the time where the, I'm sorry, I'm just passing. Yeah. Door to puncture time is extremely important. That's the time from the time patient reaches the door to the time you take them to the cath lab and puncture. And then the other time that is measured is from puncture to the first pass and puncture to recanalization. Puncture to recanalization today has come down to less than 30 minutes on an average. So our stroke thrombectomy procedures are pretty fast. So, I mean, in Apollo hospitals, we have made a little change in the system so that when the patient hits the emergency room or when they receive the information, we have divided into 4 phases. Phase 1 is before the patient is actually received. When they receive a call that a stroke patient has come, the secretary, nurse, the registrar and consultants have to prepare themselves to receive the patient practically. Phase 2 is a pre-CT. As soon as the patient is received to the time the patient has got to the CT room, then phase 3 is when the CT and CT angio imaging is being done, and phase 4 is the post CT angio imaging. So everybody has a role: the secretary, nurse, the registrar, the consultant, the neurology team, the endovascular team, the pharmacy, radiology tech. Everybody has to be communicated and they should be on toes so that the delay is avoided and they can perform the imaging quickly and make a decision on the treatment of the stroke patients. Obviously, the neurosurgical team, endovascular team is though last to come into picture. They are informed early, well in advance, so that they are able to prepare the cath lab and get things moving so that there is no delay in treating these stroke patients. And we have a timeline for these, and we try to achieve those timelines. The other going forward, telestroke units are very well developed in the Western countries, but in India, it's in a very primitive stage, and we have been striving to achieve this, but not to a great extent, but we have been pushing to get this done. Telestroke units, patients coming to a smaller hospital can have a teleconsultation with a neurologist in a bigger hospital, and then they make a decision on whether the patient can be treated in the peripheral hospital with just thrombolysis, or the patient needs to be shifted to a major hospital for a thrombectomy. So that thrombolysis can be initiated in the smaller hospital and the patient can be shifted. Going forward, future direction is that we have newer devices coming in, and we have plethora of devices today, and we are able to select devices based on the type of occlusion and the level of occlusion that we have. Telestroke units are being designed. CT ambulance have been proposed, and I think in Coimbatore KMCH has one, and more CT ambulances are being used in the Western countries for shifting the stroke patients, so that the CT is done in the ambulance itself, and the information is passed on to the receiving hospital so that they are well prepared and take the patient to the cath lab. Going forward, the cath labs are now enabled with CT scan itself. So we have the concept of direct to cath lab. As soon as the patient arrives in the ER, when we know it's a stroke patient, patient goes to the cath lab. We do a CT with CT perfusion in the cath lab itself and make a decision whether the patient needs thrombolysis or a thrombectomy. If it's a large vessel occlusion, now bypassing thrombolysis, people are going for thrombectomy. That is a newer frontier that we are trying to achieve. So the challenges in the Indian setting is obviously a lot more, but in the hospital, you have control: formation of the stroke system, formation of a stroke team, the infrastructure, data analysis, feedback, and improvement can be done within the hospital. You have control of this situation, but you don't have control of this part. That is a patient education, pre-hospital emergency services, pre-hospital emergency physician awareness. So these are the things we can strive to improve by creating various awareness programs. So to conclude, I think I've taken a lot of everybody's time. Time is brain, and we need to be aware that stroke can be treated for up to 24 hours. In the first 4.5 hours with intravenous TPA, and in up to 24 hours with mechanical thrombectomy. Beyond 6 hours, we select patients based on the advanced imaging like CT angio or MR stroke protocol imaging. And stroke system of care in each of the hospital is extremely important. You have to implement it with a very thoughtful way, and processes have to be kept in check and balances, and you have to revisit the system of care so that when a stroke hits, all the care goes seamlessly. And you should have an equipped infrastructure to achieve this. Thank you. Thanks, everyone. if anybody has a question, I'll be happy to answer, sir.
We will start it, sir. So
Thank
it
you,
was an
Dr.
exhaustive discussion, sir. So first we will have the first question of the day before starting our discussions. So I request Naveen to show the first question. First question on the screen.
Naveen, it's not opening.
Sir, is it visible, sir?
No.
No.
One second, sir.
First question, in acute ischemic stroke, what is the timeline for thrombolysis? In acute ischemic stroke, what is the timeline for thrombolysis? I request the PGs to answer it immediately. The first answers will be given the first prize. The answer should be exactly what? Okay. We can have the discussions now. And then
Yeah.
we will answer after 5 minutes. We will answer the first question. Now we can go for the discussion. Naveen, you can close the screen.
Hello, Dr. Srini. It's a very wonderful, I would say, an elaborate showcase of the stroke in general and the interventions you did. It's wonderful too. A lot of things we all learned, which some of hidden things were there and it came to the open.
Thank you.
I just have a question.
So wonderful.
This, how often do you see in a post-thrombectomy patient, you have a breakthrough bleeding? And what are the percentage of those kind of patients do you see? Because we tend to see those kind of patients also. And the second is, does it come in the large vessel occlusion or is it in the medium and the small size occlusion where you do a thrombectomy?
Yes, sir. This is a very important question because this is one thing we have to keep in mind always and counsel the family even before we do a thrombectomy. Because with thrombectomy, which is a major procedure, which is a cost burden to the family, and then we go for another procedure of decompression immediately, the family will be taken aback and they will be extremely resistant when you don't inform them upfront. So we see this if you poorly select patients. For example, if you're treating patients with a lower aspect score, patients with a mild hypodensity already established on a CT scan, our rate of reperfusion injury and going for a decompression will be significantly higher. If you properly select a patient, the risk of reperfusion hemorrhage is in the range of about, say, in most studies, it's in the range of about, say, 15 to 20%. And I would say in my practice, I would say in about 20 to 25%, 1/4 of the patients may go on for a reperfusion hemorrhage, but it doesn't mean that the whole area is totally damaged. Even with decompression at 3 months, they do quite well. So decompression is not a bad idea after thrombectomy. And if it happens, if the patient needs so, we can go ahead with the decompression. And the patients do well at 3 months compared to patients who have never had a thrombectomy.
Srini, what is the actually as a selection criteria, as a take-home message, what are the selection criteria you will take for thrombectomy?
Yeah, for patients who come within 6 hours, we don't do any advanced imaging. We do a CT with CT angio, just look at the block and we go in and take out the clot and do a thrombectomy. For patients who are coming in those patients within 6 hours, there are few patients where I will be apprehensive for patients who have already established infarcts. For example, in the plain CT scan, I look at the loss of gray-white differentiation. If there is a lot of loss of gray-white differentiation compared to the opposite hemisphere, then those are the regions which are already infarcted. or sometimes you see an established infarct, like you see black spots. For example, the timing of onset is not very clear. You may see an established infarct. So those are the patients who will also do badly when we do a thrombectomy. So these are the patients you try to avoid. You explain more carefully to the families, because in our settings, patients are paying from the pocket. They need to be explained very clearly. So these are the patients you don't give them a lot of hope, but tell them that we have to try and open it and get their consensus, get them on your side before doing a thrombectomy. Whereas in other patients where the CT scan is pristine or CT scan is clean, you just have to go right away and do a thrombectomy.
No,
So
actually, my
selection of
question,
patients.
another question is, if you are not thrombolizing the same patient, for example, if a bad patient, you are selected for thrombectomy, or if you are not doing thrombectomy, what is the difference in between these two groups?
Yeah, see, generally in most centers where large volume studies, multi-center studies have been done, people have proven that thrombectomy after thrombolysis have given a relatively better result than going for direct thrombectomy. But the caveat here is thrombolysis is done for, say, medium vessel, small vessel, as well as large vessel, whereas thrombectomy is designed for large vessel. So there are centers in Europe which practically go on for a direct thrombectomy. In India, we don't have a strict guideline with regards to thrombolysis. If you feel that it's a large vessel occlusion and cath lab is readily available and you're equipped to do it, you can go for a direct thrombectomy as well. There are not a significant difference which has been proposed in Europe, at least in Europe, where the centers which do direct thrombectomy, they have shown that in their centers, there is not a significant difference between thrombolysis followed by thrombectomy or going for a direct thrombectomy. So it's an individual choice and your experience, and a large multi-center trial has to happen with the newer thrombolytic device, that is Tenecteplase, to prove that thrombolysis followed by thrombectomy is useful and that is the way to go. With regards to reperfusion hemorrhage, there is not a significant difference, because we have to understand this thrombolytic medicines are very short acting. The Alteplase we use is only acting for 5 minutes. By the time we get to the cath lab and puncture the patient, the effect of the drug is gone from the system. Tenecteplase is only about 20 minutes. By the time you get to the cath lab and puncture and recanalize the vessel, the effect of this thrombolytic medicine is gone. So as far as the reperfusion hemorrhage is concerned, the thrombolytic medicine does not have a say. They claim that your ability to retrieve the clot, ability for the clot to be more softer for you to remove is better when you use a thrombolytic medicine. That is what the discussion or the point of contention is.
Now the time for the first question answer. You can tell the answer, sir. First question.
Yeah, the first question.
In acute ischemic stroke, what is the timeline for thrombolysis?
Yeah, most people have answered right. Yeah, thrombolysis is first 4.5 hours. You can do a thrombolysis and either using Alteplase or Tenecteplase. 4.5 hours is the timeline. Most people have answered right. I mean, or everybody who have answered right.
Now the time for the second question. Naveen, second question.
Sir, second question.
Not visible in the screen. In acute ischemic stroke due to large vessel occlusion, what is the timeline for thrombectomy? In acute ischemic stroke due to large vessel occlusion, what is the timeline for thrombectomy?
I think this question is interesting and yeah.
Okay, we can go for the discussions. Continue.
What is the difference of?
Sir, you are telling about the. You are telling about we need to educate the people like that, sir. in what way we can educate our people, sir? Because the education needed not only for the public, sir, it is needed even for doctors, sir, even for us also. If we face any one of our family members getting suddenly an acute problem, a stroke like that, immediately what we should do? That guidelines you should start telling, sir. That only will change the whole scenario. We people are talking about the brain attack and பேசிட்டே இருக்காங்க. But no one is coming out with, we have to create a nice protocol, because you are having a nice protocol in your institute. The same protocol has to be followed throughout. At least from the TANS itself, we can create a new guidelines also. With your help, we can create a guidelines. If anyone happens to have a problem, what we should do to educate the people, and also to educate our doctors and even the neuro doctors. Because if suddenly anything happens in our family itself, we are not able to, we are not doing correctly. That
Yes,
is the
sir.
situation.
It's a very good question. Actually,
That is the very real situation, sir.
yes, yes, yes.
ஒண்ணும் இல்லை, எங்க ஃபாதருக்கே 10 இயர்ஸ்க்கு முன்னால அவர் வந்து பாத்தீங்கன்னா சடனா வந்து நான் வந்து ஈரோட்ல இருந்தேன், அவர் வந்து கோயம்புத்தூர்ல இருக்காரு. அவர் வந்து சொல்றாரு, எனக்கு வந்து கையில பேசுறாரு, என்னால வந்து பட்டன் போட முடியல அப்படின்னு சொல்லி 6:15 மணிக்கு சொல்றாரு. அப்ப வந்து இமீடியட்டா அங்கிருந்து என்ன ஆன்சர் பண்ண முடியும்? சரி, நீங்க பக்கத்துல இருக்கிற டாக்டர் கிட்ட இமீடியட்டா போங்க, அவர் பார்த்துட்டு உடனே ஸ்கேன் எடுப்பாரு அப்படிங்கறது தான் நம்ம சொல்றோம். சோ அதை விட நம்ம என்ன ஆக்சுவலா பண்ணணும், அதுதான் வந்து that is what needed.
Yeah, as far as the common man or a public is concerned, I mean, when I give a talk to common man, for example, some senior citizen forum or other things, I will teach them more on the BFAST, that is a painless condition where they are not able to use certain parts of the body, like loss of balance. If they all of a sudden feel imbalanced, or if they have a vision disturbance, or if they have a drooping face, or if they have an arm leg weakness, they have to immediately reach out to a hospital which has all the facilities. Unfortunately, we live in a situation where the ambulance services are not great. I mean, though we have good ambulance services, the ambulance services are not equipped or oriented to take the patient with a stroke. They don't have a stroke code related sensitivity. In the Western countries, what happens is somebody they pick up, immediately they pick up a stroke. The ambulance is designated to go to a hospital, and they have designed the hospital as a stroke ready hospital or a comprehensive stroke center. They either take them to the stroke ready hospital, and if it is a minor stroke, they treat there. If it is a major stroke, immediately the ambulance waits there and shift the patients to a comprehensive stroke center. We don't have a designation like this. So our people, we need to equip them in such a way, or teach them in such a way, that they have to go to a hospital where there is an in-house CT scan, in-house treatment facility. For example, if the patient comes to a hospital, the assessment is done, patient goes to an outside center for a CT scan, the whole idea of stroke treatment is gone. They cannot be treated. They go to a scan center where by the time the patient comes back, it will already be 2 hours. By the time the scan report comes, it will be already 4 hours, and we lose all our window period. So we need to practically get them to a hospital which is equipped with the CT scan or an MRI, so that a diagnosis of a stroke, and whether it is a small vessel or a large vessel stroke, is immediately done. And if cath lab is available, and if the hospital is equipped with thrombectomy, I mean, obviously thrombectomy will be done in that hospital, or at least thrombolysis will be done.
That's a good point. Actually, most of the patients in our setup, they are reaching late to the hospital. Today also, I inquired about one patient. No, they came after 24 hours. So most of the window period we are missing. So we have to educate the patient in such a way that they should reach a comprehensive setup.
Yeah, most patients who reach out to us, I mean, in Chennai, it is unfortunately filtered by a lot of small hospitals. They reach us much later with an established stroke, and most of the time a scan is done at an outside hospital, and it is a very common scenario in spite of us teaching people. But people who are aware, I think we should start teaching about the symptoms of stroke even to school children, so that they can pick up the stroke symptoms in their parents or like in their grandparents, and we should sensitize them that they should reach out. Stroke is a serious business, and they should reach out to a hospital with all the facilities.
one of the common things what we find is they'll have this thing where in the periphery, when a patient goes to a smaller hospital or to a neurologist, they tend to treat them with antiplatelet drugs and anticoagulants. They may not know which is the right time to refer. They may think that, okay, I can treat this patient, I can treat with antiplatelet and I can treat with anticoagulants, and they may not refer at all. Many of the patients get filtered there itself at that level, the periphery itself. The awareness has to reach the patient or the people or the public. Only then it's going to happen. I mean, otherwise it's going to be filtered in the peripheral centers itself. By the time they come here, it's too late. What do you think?
Absolutely, sir. Absolutely. I mean, among the IMA talks I have given across Chennai, I felt that I'm just wasting my time. I should reach out more to people and reach out to the common man and create awareness to treat strokes. I mean, if I'm really inclined to treat strokes, I should not be wasting time in IMA talks. I should be reaching out to people directly.
You're right. Right.
Hello.
Sir,
Yes,
now
sir.
it is answer for the second question, sir. In acute ischemic stroke, due to large vessel occlusion, what is the timeline for thrombectomy?
Yeah, as per the current standards, our timeline of treatment is 24 hours today. So 24 hours is the right answer. Few people have also answered 6 hours, and in selected patients up to 24 hours. That's also a correct answer. So today the timeline remains at 24 hours.
Okay, now the third question. Naveen, please show the third question. What are the two basic techniques of thrombectomy? What are the two basic techniques of thrombectomy? This is the question. You can start answering. Two techniques you have to give, then only you will be given awarded. All of you can start doing it. Okay, we can continue the discussion, sir.
Dr. Srinivasan, this is Dr. Srinivasan.
Sir, good
Sir.
evening.
Welcome, sir.
Excellent presentation. I really appreciate the time and effort you have put in, and it was very useful. I mean, it's a complete coverage of a stroke. The only concern I have is there may be an accusation that you are doing overkill. Okay, that's the one thing. The second thing is the jury is out. No, I do not know how many neurologists are here in this group right now. So they are the one who get these patients at the outset. So I think they are the your customers. You need to talk to them and sensitize them, and then get them into the team before you could proceed further. So the basic question is, are you blamed that you are treating TAs which could be left alone, will make a good recovery on their own?
Not
just
really.
I'm asking you.
Yes, sir. Yes, sir. This is a very valid question. I mean, in the beginning, when it's a clear, simple disclosure. In the beginning, when I returned from the US, I treated a lot more strokes than I do now. I've become very selective nowadays. The reason is that there we work above the recommendations or the guidelines. The guidelines are just a benchmark, and we work above the guidelines. And you think some patients will benefit, even some part of the brain can be salvaged, you can go ahead and do a thrombectomy. So I did more decompression to begin with. But nowadays, I'm very careful in selecting these patients, because if more and more patients go for a decompression and then they have a long course of recovery, overall, the neurologists will get fatigued out. I mean, you have to be very, very careful when neurologists are in your team, and they have to understand what you're doing is really helping the patients. Because people have, before I came back, there were people who were trying this and they have really spoiled their own practice because they were giving bad results. And we have to show better results and good outcomes for neurologists to believe that this is effective, and for us to be part of this treatment, we have to make sure that we are selecting our patients correctly. So today we select our patients, anybody beyond 6 hours, without a proper MRI or a perfusion imaging and properly selecting these patients and having a detailed discussion with the family, we don't go into the cath lab at all. And
the other thing is, so if you see 100 cases in a emergency department in Apollo, how many of them you end up onto the cath lab?
Yes.
You have any statistics on that?
Yes, if we see 100 cases, about 10 to 15 cases are eligible cases for thrombectomy. I'm talking about the whole lot of stroke. That is, a lot more strokes are distal vessel occlusion, small vessel occlusions, TIAs, and a lot of them receive thrombolysis. If you say 100 strokes, say about 50 or 60 will receive thrombolysis, of which about 15 or maximum 20 you do a thrombectomy.
Okay.
And that is the ratio.
Okay, excellent. That clears the air. So you have to target those groups. So you need to sensitize the physicians and the neurologists who are the touch points, first touch points. And the same way the nursing homes, the smaller nursing homes, they have the first touch points. You should sensitize them. You identify these are the patients, you refer to me at the earliest. So I think that is the gap we have to address to make it work it better, so that you get more and more patients onto the cath lab.
Absolutely, and case selection is extremely important, and that comes with a lot of experience, and people have to really be involved in these procedures and the care of these stroke patient overall, and see their outcome at 3 months for somebody to be able to make these decisions as a whole. So people have to be more focused towards vascular, and just doing it one-off once in a while, decision making can be very, very, very difficult in stroke treatments.
One more question. I mean, it's a basic question. The outcome basically depends on the collaterals.
Correct.
Correct. Now, is there any way you could improve the collaterals in a lifestyle modification so that these basic strokes can be minimized in the community? I'm looking at a larger picture.
Yes, sir. I mean, for the brain, there has not been a technique or a suggested way to improve the collaterals, unfortunately. But for the cardiac, obviously, it's a muscle. The more you work the muscle, the chances of collateral development, even if there is a large vessel occlusion, has been proposed. But unfortunately, for the brain, there are no such therapies proposed to improve the collaterals.
Any research level?
There has been research level, but nothing has been proven to be effective, or as far as I know, nothing has been really been proposed to be effective, and no recommendations have come out of it, sir.
Because that is the key thing which decides the ultimate outcome. If someone has got an excellent collateral, even one of our recent patients has got 3 vessel blockage. He's got only 1 vessel, but he's walking.
Yes, sir.
He's got excellent collateral. So some of them
on the stick.
Yes. Okay.
Thank you very much. To answer your first question, just to complete my answer for the first question, with regards to the overkill.
Yeah.
Actually, in today's world, the research has been to push the limits of stroke treatment. In Canada and the US, there have been large studies happening where they treat patients with aspects of 4 and above. We usually don't treat below 6.
Okay.
7, 8, 9, we tend to treat. Aspects of 4 and above, they are treating patients. They claim that even a small portion of neuron you salvage, at 3 months, they are going to benefit. So, and they are pushing the limits toward more and more smaller vessel occlusion, which we can't practice in India like that, because those patients will go for more decompressions, and I can't sustain my practice with every patient that I do a thrombectomy.
I understand. I am with you. I'm just, creating a counter question so that you are ready to answer. Sure, Thank you. Excellent presentation overall. I enjoyed the session.
Thank you.
Sir, now the answer for the third question. Sir, answer for the third question.
Yes, sir. The answer for the third question is, I think I'll just see the chat box, what people have answered. Yeah. Yeah, perfect. Yeah, people have answered good. So the 2 techniques is stent retriever and aspiration, direct aspiration. So stent retrieval and aspiration is the right answer.
Yes, sir. Now the 4th question. Naveen, you can show the 4th question. What image strategy is used for selection of patients for thrombectomy beyond 6 hours of onset? What imaging strategy is used for selection of patients for thrombectomy beyond 6 hours of onset? Okay, we can continue the discussion, sir.
This is Dr. Murugesan
Murugesan
from
is
Coimbatore.
online. He's waiting some questions.
Yeah.
Those who want to tell the questions, you please raise your hand, sir, so that we can ask one by one, sir.
Okay.
So all of you, please start putting your hands up. Now
This is-
Murugesan can start.
Yeah. This is Dr. Murugesan from Coimbatore. Srini, a very good presentation. You covered almost everything about stroke. Actually, my question is, if the patient comes early, that is within 4.5 hours, that is around 3 hours, whether we can directly go for thrombectomy or can we go for bridging therapy, which will be better? Is there any criteria to decide that?
Yeah, this is a good question in a global scenario. See, the way it works is in the US, United States, for patients coming within the 4.5 hours, it is mandatory to give thrombolysis because that is the FDA approved treatment. So they are bound to give thrombolysis. And if the patient has to be taken for thrombectomy, subsequently they take them for thrombectomy. Whereas in the rest of the world, there is no real pressing need. If there is a large vessel occlusion, patient can be taken up for direct thrombectomy as well. There are few studies which have shown that, not a multi-center study, but anecdotal studies from few centers have shown that thrombolysis followed by thrombectomy have relatively given better results at 3 months compared to direct thrombectomy. On the counterpoint, some centers have given results stating that for large vessel occlusion, direct thrombectomy is better. So we don't really have an answer whether thrombolysis aids or helps in subsequent thrombectomy. So in an Indian scenario, if you see a large vessel occlusion, you can go for a direct thrombectomy as well. On the other hand, what is the downside of giving thrombolysis? There is not a significant downside. I mean, the effect of the risk of hemorrhage is not higher with thrombolysis when you do a thrombectomy following a thrombolysis. So there is no real downside. Only downside is it adds to the cost. So you can make your decision based on that.
The timing.
If you have the ability to do thrombectomy and you have the cath lab available and you have the trained personnel available, directly going to the cath lab is not a sin.
Okay. Thank you, Srini. Is there any correlation between the clot burden and the direct thrombectomy? We can skip thrombolysis, directly go for thrombectomy.
Correct. See,
Clot burden, the size of the clot, or
in a small vessel, in a medium vessel and a small vessel, the thrombolysis, the chances it may work is more than 40%. Whereas in a large vessel occlusion, for example, an ICA occlusion, the clot burden is higher because it's a big thick chunk of clot blocking the ICA. The chances of thrombolysis might work is less than 20%. So obviously in a large vessel occlusion, that's the point of argument where people go for a direct thrombectomy. Certainly smaller clots are lysed easily than the bigger clots.
Okay. Thank you, Srini.
Thank
you.
Now
Very good
answer for
presentation.
the fourth question.
Interesting.
Yes, sir. Let me see what people have done. Yeah. Yeah, I think people have answered differently. Yeah, the answer is you can either do a CT perfusion or MR perfusion imaging, or MR. Even if you don't have a perfusion imaging, you can use a MRI stroke protocol where you do a DWI imaging with a flare image. So I would go with either a CT perfusion or a MR imaging would be the right answer. Yeah, whoever has mentioned perfusion imaging, I would take it, sir. So perfusion is the key word there. So either a CT or a MR. If they have mentioned a perfusion imaging, we'll take that as the right answer.
Okay, now the fifth and last question. When is the good and standard time to assess the outcome of stroke treatment? When is the good and standard time to assess the outcome of stroke treatment? Okay, we can continue the discussion, sir.
Dr. Srini, one question. Do you
Yes.
have, if you see a hypertension sign on CT, like an MCA, what are your things like? Is it a favorable thing for a thrombectomy, or would you think it may be a little calcific? In the case it's calcific, do you have any chances that you may have a negative result on thrombectomy, you're not able to do it? Have you come across these situations?
Yes, sir. We do quite often come across this, especially in Indian scenario. There is a lot more atherosclerotic disease than the Western countries. And hyperdense MCA sign is practically an hyperacute clot. The hyperdense sign is different from an MCA calcification, because MCA calcification is very localized and it is more hyperdense than a MCA sign. Practically, MCA sign is a longer course of the vessel is highlighted, and it appears less intense on a CT scan compared to a calcification. When you are looking at a calcification, then we have to be extremely be cautious while doing thrombectomy, because the technique is completely different and we may have to end up stenting these patients. And when we do an angiogram, the initial run in an atherosclerotic disease with occlusion, it will invariably show a tapered end in the angiogram, whereas a clot will have an abrupt cutoff. So that will give you an additional clue whether it is a clot you're dealing with or an atherosclerotic disease. In either way, if I think it's a clot, I would go with the direct aspiration first, then combine it with the stent reaver if needed. If I think it's an atherosclerotic disease, I wouldn't go for an aspiration first. I would go directly first with the stent reaver. And if it doesn't work, because when you put a stent, obviously the stent will expand and it will improve the flow. And after you take it out, there will be no clot and the vessel will shut down again. And if it happens 3 to 4 times continuously, then I know that I'm dealing with an atherosclerotic disease. And if I think the aspect score is good and the patient is not going to have a major stroke, I may look at acutely stenting this patient after giving GP2B3A inhibitors and aspirin through Riles tube.
Thanks, Srini. Yeah.
Sure,
Sir,
sir.
actually, sir, one small thing I want to know is, what is your real protocol? A simplified protocol you have, so that we can directly suggest to all people. Whether you have any simple protocol for
Yes.
acute stroke.
Yes, sir. We get residents who rotate with us every 3 months. So we practically train them and tune them to react to strokes. And in good number of scenarios, even before the neurologists see, our residents see the patient, and we are geared up for the treatment. And in fact, they may talk to the neurologist and get consensus on thrombolysis as well. So the simple thing is, anybody who comes within the first 6 hours, we do a CT with CT angiogram. And if it is a large vessel occlusion, and if it is, with the CT angiogram, there is no bleed, then it is an ischemic stroke, and the patient is eligible within the 4.5 hours for thrombolysis. And if it's a large vessel occlusion, we also get prepared for a thrombectomy. For patients coming beyond, say, 6 hours, we don't do a CT angiogram. We in fact do a CT perfusion. CT perfusion or MR perfusion or MR stroke protocol imaging. So this is the standard protocol we have for our patients, and our residents are quite aware and they immediately evaluate the patient. And even before I talk to them, they call us and tell us, sir, I have a potential case for thrombectomy. So you tune them for 15-20 days, they are fine, and they will assess the case and get you the results. They are like a rapid software.
Sir, how about the Tenecteplase? Immediately you give straight away when they come, or wait for some time?
Sir, when the patient is in the CT room and we see the patient has clinically a stroke and the CT does not show a bleed, ideal time to give Tenecteplase is before the patient is taken out of the CT, sir. In the CT
So what
room,
is the dose? What is the dose you commonly use?
yes, sir, the dose is about, there are various doses proposed, but the ideal dose where the risk of hemorrhage is less is with 0.25 micrograms per kilogram is the ideal dose to be given. There are trials
Given as a bolus,
yes,
direct bolus.
given as a IV direct bolus. 5
No
minutes.
dilution.
Yes, sir.
What is the brand available now, sir?
I think in Apollo we have one Tinac, and I'm not sure about the various brands available. There is only one brand available with us in Apollo hospitals.
Tenact.
Yeah.
So now the time for the fifth question, sir. Answer.
Yeah, the answer for the fifth question, I think everybody has answered right. I think the stroke patients, when we look at their outcome, the neurologists have to be sensitized. The neurologists think that every patient goes to the cath lab will come out completely all right, better. It's not MI we are treating. MI, even if significant amount of heart is not functioning well, the patient gets better and he can walk back home. He may not have a significant deficit. But in stroke, patients will have deficit. A good number of them will get to a good functional level. And this getting back to the good functional level needs a lot of effort apart from thrombectomy. Some patients will improve on the table. They will start lifting the hand. Some people will improve the next day or within a week or within a month. Some people with rehab, they will get better. So all these patients are assessed, and we think the final outcome or a good amount of functional outcome is restored in about 3 months. So 3 months is the time we assess the outcome of these patients.
Hi, Srini. I just want to add a comment. Quite a few patients who have underwent thrombolysis and they land up in decompression. And quite a few patients after thrombectomy, they also end up in decompression. But the patient who underwent thrombectomy and end up in decompression, they do much better. I think it's a salvaging. Some part of the brain is happening, even though they land up in a decompression. Some part of the brain salvaging is happening. So thrombectomy is even some part of a functional recovery. Even after decompression, thrombectomy is useful. So we need to be more proactive and more aggressive in thrombectomy. Maybe in future, I think, even though they don't recover completely, some sort of functional recovery is there, especially young people.
Absolutely, absolutely. Based on this kind of experience, only people are pushing towards thrombectomy, even for lower aspect score and people with the salvageable brain. Generally, the criteria taken is if more than 2/3 of the MCA territory is infarcted, you don't do anything. If less than 2/3 of the MCA territory is infarcted and you can salvage even like a part of it, then you can go for a thrombectomy. So that is what large centers in Canada and some centers in Europe under trial are doing thrombectomy for nowadays. They are pushing the limits based on the similar experience that you have, Karthi.
Yeah, that's why even a small functional recovery, by say, is able to stand on his own rather than completely hemiplegic. I think thrombectomy might be worth a try. Maybe future we may have a guidelines maybe changed, I think.
Yeah, absolutely. This point of like a left-sided hemisphere where the speech is involved, even if it is a distal vessel occlusion, a small, say, angular artery is involved, the comprehension will be significantly impaired. You can go distally and remove a thrombectomy. The patient will have a significant functional recovery. So this is another territory where, especially the left hemisphere, we are very, very aggressive, even for medium and distal vessel occlusions to do thrombectomies.
It's quite contrary to what people say. Left side hemiplegia, decompression. Even though we do decompression, they don't get better because of this morbid functional disability. Some part of the brain is able to recover because of a thrombectomy. I think it's definitely going to help him in his long run.
Correct.
Any other questions, sir? So if there are no questions, we will finally announce the results. The winners. The winners will be given a gift check of around 2,000 rupees. And the first prize winner is, first question is Dr. Nagavishnu Shankar. Is Nagavishnu available?
Hi, sir.
You are from which place?
Sir, Tirunelveli Medical College. Tirunelveli.
Very nice, very nice. Congrats, congrats.
Thank you, sir. Thank you.
For the second question, the winner is Christy Bernard. Christy Bernard available?
Yes, sir, I'm available.
Yes, come on. You are
So
from?
I'm from Stanley Medical College, sir. Final year neurosurgery resident.
Congrats, congrats.
I think I saw Christy Bernard answering more than one question.
Yeah, that's what the 2-3 people were going on answering. That's why I was telling in the beginning itself, if they are answering the twice and thrice, we will go for the next person to give a chance to give the award. That's what. So now the third question, winner is Dr. Nalini, who is on iPhone, and if Dr. Nalini is available. Dr. Nalini. We will inform the winner then later. Then for the fourth question, it is Dr. Tamil Anand. Dr. Tamil Anand available?
Yes, sir. Good evening, sir.
You are from which college?
I'm from Meenakshi Mission, Madurai, sir. 5th year resident.
Nice. Very nice. Congratulations. Congratulations. Your professor has not come, huh?
I think
your professor has not joined, I think.
Yes, sir.
So for the fifth question, the winner is Dr. Sivangi. Dr. Sivangi available here? Hello? Is Dr. Sivangi available here? Okay, congratulations for all the winners. Dr. Nagavishnu Shankar, Dr. Christy Bernard, Dr. Nalini, Dr. Tamil Anand, and Dr. Sivangi.
Yeah,
Dr. Sivangi from which college?
Available.
You are from which college?
You have to unmute yourself, Shivangi.
Unmute yourself.
Shivangi, you need to unmute.
She is searching for the unmute button.
I think Dr. Naveen can unmute her.